I have a keen interest in oncology, and interestingly, particularly upper tract TCC is fairly uncommon, and so there's a few of us that see it. And interestingly, over the last 6 months, I've had a bit of a rush of it, but there's clearly a crossover between the disease process of transitional cell carcinoma in the kidney, the bladder, and then down into the urethra. And so it's the upper and the lower end that we'll have a look at tonight. So I'm just going to make sure I'm going to click through this. So we'll start with upper tract urothelial carcinoma. So there was a bit of a nomenclature change a few years ago, and we still use it somewhat interchangeably. A TCC, or transitional cell, is basically the same as urothelial cancer, and they just like to change the name, but it's the same disease process. So it's the cell, the urothelial cells that line the bladder, but also line the ureters, which are the pipes, and up into the renal pelvis in the kidney, and then down into variable lengths of the urethra, which we'll come to later on. And so the cancer can occur, transitional cell or urothelial carcinoma can occur anywhere from the kidney, so the inner lining of the kidney in what's called the calyces, where the urine is produced, the renal pelvis, not the anatomical pelvis, but the renal pelvis is sort of the collecting area within the kidney for urine, all the way down the ureter and then out, because they're all the similar cell type, and therefore there's a lot of linkages and similarities between the cancers here. But what's important is that this is quite rare. It's the same cell type, but this speaks to often what we think is the likely cause of urothelial cancers, which is some form of interaction between something in the urine and the lining. And so that's why we feel that there's probably a much higher incidence of these in the bladder, where they dwell inside the bladder, whereas in the kidney and the ureter, they're often passing through, so there's less contact time. But they're far fewer, far rarer. So it's only 5% of these types of cancers occur up in the kidneys or the ureter. It's only 5% of kidney cancers. People often ask, is this actually a kidney cancer? Well, it's within the kidney, but it's a different type of tumor. Those are actually renal cell carcinomas. It's uncommon, but it can happen bilaterally, so that means on both sides. But again, as with bladder cancer, it's increasingly common as we age. So there's an increasing age of incidence there, with men typically more common than women. And historically, that's been because of the smoking rates and exposure. Although we do know that that's changing as the numbers become a little bit more equal. But as I've said, 90% of urothelial cancers, there are some other rarer subtypes that we do see in the bladder, and these are the squamous cell or the adenocarcinomas, but again, they're very uncommon in the upper tract. You will know these fairly common symptoms that most bladder cancer patients are aware of. Blood in the urine or hematuria is the most common warning sign. And so whenever we see visible or what's called microscopic blood on the dipstick or the urine test, we are always checking the bladder, but we are always checking the upper tracts. So we're doing something like an ultrasound or a CT scan to screen for causes of this in the kidney, because blood can come from anywhere from the kidney itself all the way down to the meatus, which is the opening of the urethra externally. There are often the other symptoms of severe disease with weight loss and loss of appetite. And sometimes when people have lesions and masses, this can predispose to infections. But here we look at those main risk factors for upper tract urothelial carcinoma, and it's all the identical risk factors that we see for bladder cancer. Smoking, unfortunately. There's the use of analgesics and these sorts of medications that are uncommon now, having ceased in the last couple of decades. There's exposure in terms of occupational hazards and people working with certain chemicals. Previous chemotherapy and radiation, we do know that that predisposes to cancers here. And there are some syndromes, particularly Lynch syndrome, which looks at familial cancers, particularly people who have lots of bowel and gastric cancers. It's the polyposis syndromes, but these Lynch syndrome patients have a higher risk of this specific cancer. Inflammation, as in the bladder, is a risk factor for the squamous cell carcinomas, and it's the same in the kidney, where if you have lots of chronic infection, then we can see this with recurrent stones or foreign bodies. But the biggest risk factor for upper tract cancer is prior bladder cancer, because clearly a process is occurring where urothelial cancer is generated. So the incidence of it is up to 50% for those people with prior bladder cancers. And then there are elements to their previous bladder cancer which might predispose them higher. So if it's closer to the ureteric orifice, if it's multifocal, if someone has reflux with bladder cancer, then these are circumstances where it can predispose to it being in the upper tract. As I've said, there are a couple of subtypes. So transitional cell urothelial is the vast majority, and we've got the other subtypes mentioned. There's theories around whether it's a monoclonal or a field change, and this is where we talk about some of those treatments with the immunotherapy within the bladder to treat the whole field, because that's where cancer can occur in the entire field. That's what we need to treat. But then there's the theory behind seeding, and if you have a tumor up in the kidney, then that's where we sometimes see multifocal disease in the bladder, and we always screen in the upper tract. And this is where we often see more tumor at the distal end of the ureter, because that's where we feel that the cells might be seeding to, and there's a bit of stasis. So they sit there and can dwell and can implant in the ureter. So that's where we see a preponderance, more so in the distal ureter than up the top. The staging, I thought I'd list there because some people are interested, and it's the standard T and M. And basically the T is the most important bit, where it talks about how deep it grows. And that's what we all know with bladder cancer also, whether it's into the muscle or deeper tissues is the really important element. And that speaks to the survival rates as well, because once it gets through the muscle or the elastic layers, then it is a more aggressive tumor. Interestingly, if it's in the kidney, it doesn't have as nasty a prognosis, because you can imagine that there's a lot more tissue around and within the kidney, so it can't get through and out. But if we're looking at the ureter, the pipe, it's quite narrow, only a few millimeters diameter with very thin wall. Then if the tumor's in that area, then it's far easier for it to get out and spread. So we're a little bit more wary of those that are in the ureter than in the kidney. General assessment, same sort of standard approach to bladder cancers, with looking for cancer cells, imaging to look for what you might see as a filling defect. And then we do use the PET scans, which you may be aware of in bladder cancers, because the cells are quite metabolically active. So similar to the bladder cancer cells, they are quite active in the urothelium, in the kidney and the ureter. And the real key way to diagnose these, apart from CT scans, MR, is to take a biopsy. And so that's typically with a cystoscopy, so looking inside the bladder. We do what's called a retrograde study. So we do a dye test, and you can see that on the right-hand side, although you're all obscuring it for me with where you sit in my screen. So there's a filling defect in that mid to upper area where we should see smooth filling. And then generally nowadays, because it's a fairly straightforward procedure, we use these very fine, what are called piloscopes or flexible ureteroscopes, to go up, have a look, and actually get some tissue. Because historically we just operate or irradiate these, and now we can actually get tissue to help us treat them appropriately. Management varies from very conservative and stenting to endoscopic, where we might laser or ablate or burn or chip away these tumors, to some of the intravesical treatments, which we might give up or down into the kidney. And that's a jar of mitomycin, which you'd probably be aware of with some of the bladder cancers, but can be used here in upper tract. And then we go to segmental, so just resecting parts of the urinary tract, so part of the ureter, to the gold standard, which really is removing the whole system, because it's quite difficult to treat the ureter and the kidney as opposed to the bladder, where we can place chemicals, we can place treatments in there that will sit and dwell and interact. And that's the real challenge with the upper tract, is that there's always a forward flow of urine. So this is the general guidelines from the EAU, I think recently republished last year, which talk about low and high risk. And that's really about the grade of the tumors and how much we're dealing with. And if possible, we like to spare the kidney, because if we need chemotherapy, if someone has other comorbidities, if they have other renal impairment or comorbidities contributing to that, we'd ideally like to spare that kidney and just remove the tumor. or the segment involved with tumor. That's not always possible, and it's not always successful. And so that's where the higher risk or recurrent paradigm there of removing the entire unit. And that's the kidney, the ureter, all the way down to the bladder, and then a cuff, so a rim of that as it enters the bladder, because that's all likely involved. And the elements that we need to consider to determine that are how aggressive the tumor is. As you'll know with bladder, whether it's muscle invasive or non-muscle invasive is quite a significant differentiating point. As I said, their overall renal function, do they have other tumors? Are they candidates for such aggressive treatment? So the simple things are just, you can do a resection or a laser, but there's problems with complications of the surgery and recurrence here. As mentioned, we can theoretically deliver the same agents that are used in bladder cancer. You might have heard of BCG or the mitomycin chemotherapy, epirubicin, doxorubicin. But the problem is we need the dwell time for it to work and engender the response. It's not as vascular an organ, so we don't see as good an immunologic response. And so there is some evidence around this, but there's no consistent high-level data. And so we do use these more conservative options of ablation on the previous slide, or if we can deliver these, which might be through a ureteric catheter, so that's a small tube up into the kidney, or a tube directly into the kidney, as you can see in that diagram, to try and drip feed that treatment. But the evidence and the outcomes are not as good as when we use it in the bladder setting. Therefore, ideally, we're looking at removing segments of the ureter. So this might be a mid or a distal component and then joining it back up. Or in an ideal setting, we're taking the entire unit. So that's the kidney and the ureter, which is called a nephroureterectomy. And historically, this has been done via open, so quite maximally invasive surgery, or somewhat keyhole, but then the bottom end is performed with an open operation, and that might be a Phanon-Steele, which is the cesarean section type incision, or a midline incision. But they are still somewhat morbid. We have to open the bladder. So the most recent sort of development of this is doing it completely laparoscopically or robotically, with a fairly consistent outcome between all three. And so here's the anatomy. So it's not just the kidney that you might see removed in standard kidney surgery. The difficulty is we have to remove the unit, which is the kidney, all the way down, right down to the bladder as it joins there. And that's right almost down at the pelvic floor. If you know some of the anatomy here, the ureter is joined right down the bottom, almost near the urethra. So it's a very big area of dissection, right from the top, just under your diaphragm, down to the bottom. And that's why open surgery is quite challenging, being, needing access to all of that. But what's been great in the last couple of decades is the robotic platforms, and the newest one is even better because it can move between areas. And so the old one, it was tricky. You had to, this is a patient with their consent. She had a really great outcome just before Christmas. She was done, I think, 5 days before Christmas and was home for Christmas, thankfully, and all purely keyhole, and there's one slightly larger incision down the bottom. But the newer platform is really useful because it's you can operate from top to bottom. But there's also challenges if people have had lots of other surgery. And nowadays, patients do have other operations in the abdomen, bowel surgery, liver surgery, vascular surgery. And so one of the newer adjuncts, and it's not really done in Australia until recently, and James Porter is the surgeon. So I borrowed his video, but I did one of the first ones and presented it last week, is where we can actually do it almost through the back. And so historically here, you'd have the robot coming through the front of the abdomen, but what we call a retroperitoneal is where we go through the back. And what that means is we don't have to go anywhere near all those other organs. But the principles are still the same. We remove the whole unit. Chemotherapy is used in these tumors as well. And you may be aware that in bladder cancers, there is a clear benefit to giving chemotherapy before the bladder cancer surgery to remove it when it's advanced. And the same is here extrapolated from that, but also evidence for upper tract cancer. So we know that there is a clear benefit from randomized controlled trials, but also there's emerging evidence to give the chemotherapy before. And that makes sense because you need renal function. So if you remove a kidney and then their renal function isn't very good, then you may not be able to give them the best chemotherapy that would enhance their outcomes. Radiotherapy is uncommonly used in the upper tract because it's quite close to bowel, and so there's a little bit of morbidity trying to use it, but it can be used in the palliative setting, and that's where I have worked with colleagues to deliver that. Again, here, in terms of outcomes, there's really no big difference between the operative techniques, but once we get into T3, so that's through and into adjacent structures, then the outcomes really do decrease, and the long-term survival for 5-year overall survival. But it does differ between the ureter and the kidney, as mentioned before, because you've got that buffer of kidney. These patients need lifelong surveillance because they have risk of recurrence both in the bladder and the other kidney. They need cystoscopy to evaluate the bladder and scans regularly thereafter. So that's sort of a quick whirlwind about TCC of the upper tract from kidney down to the bladder. So I'll move on to urethral cancer, which basically is super rare. We really don't see it in terms of in the urethra. I will slightly differentiate urethra from prostatic urethra if we discuss that question a bit later. But certainly it's malignant generally urothelial carcinoma in the proximal urethra, and then it moves into squamous cell carcinoma in the distal urethra because those are the different cell types in this organ. So that organ is much shorter in women and then much longer in men, but it is an exceedingly rare cancer in this sort of paradigm. So most of them in the distal urethra are going to be squamous cell. So there's a distinction. So transition cell urothelium it's a cuboidal, so it's about 7 cells thick, and it can expand, it can thicken, and then it can thin out, and that's useful in the bladder because it needs to expand as the bladder fills and then contract, and so that's a particular type of urothelium. And then the epithelium, which is squamous, is the cell type which is much more thin and elongated, and that's what we see basically at the skin. We see it keratinizing in areas like hair or nails, but otherwise we have squamous epithelium throughout the rest of our body. And so there's a continuation where more is transitional in the proximal third, more is squamous at the distal third, and in the middle there's a crossover. So we see that in the two types of urethra, be it both female and male. So more urethral cancer is a squamous cell, and this speaks to the risk factors that we'll come to in terms of HPV. And then there's the transitional cell or the urothelial carcinoma in that proximal. And then there is the slightly higher rate of adenocarcinoma, particularly in women, because there are periurethral glands in women. And so when there are diverticuli or there are glands, these are the more common adenocarcinomas, and they can be quite aggressive, and hence why a number of urogynecologists are quite aggressive in treating urethral diverticuli, because that's one of the predisposing factors. So as said here, in terms of urothelial carcinoma, one of the biggest risk factors is prior bladder cancer. And so just speaking to that comment about prostatic urethral tumors, if it's not invasive and it's just on the surface, we can treat it like a superficial urothelial carcinoma. But once it starts to invade the stroma or the glandular structures, it then becomes a more aggressive tumor, akin to if we're talking about non-muscle invasive versus muscle invasive and how we manage that in the bladder. So it's a slightly different beast to pure urethral carcinomas, which it's a little bit different in the prostatic urethra. If we're talking about the more common squamous cell cancers, then we're looking at inflammation. And so this is where we see the linkages with HPV, infections such as STIs, and that's that linkage there, urinary tract infections and repeated urethritis, or diverticuli and strictures and recurrent inflammation in the urethra. And so that's the association there. There's the context and location that often predicts the outcome. So we do see these, and there's the age-old quandary as to whether, if we're treating someone with very aggressive bladder cancer with a cystectomy, should we take their urethra with them as well? And certainly if there is involvement of the prostate, and so more sort of distal disease, and that's why if there's aggressive disease at the bladder neck, we would often do some sampling of that area. And if it's involved, we would then be quite aggressive to take the urethra. But if it's not, then we try not to, because taking the urethra, particularly in a male, we would almost always, sorry, I'll correct myself here too by saying in women, we would usually almost always take the urethra unless we're creating a continent neobladder or reservoir, because there's no reason to leave it there. So unless we're creating a reservoir, when we might leave the urethra, and if we're going to leave the urethra in that setting, then we'd sometimes test the margins to make sure there is no further disease before proceeding. However, in men, it's a much more morbid operation. So to be taking the entire length of the urethra can compromise their erectile function, although that's often compromised with the bladder surgery, but it is a bit more of a morbid operation and you need to dissect out their pelvic floor to remove that. So often we do not remove it and then we need to survey it. And that's where we see that 4 to 20% develop recurrent cancer in the urethra. That can be often predicted by more CIS or prostatic involvement or multifocal disease where we worry about the field change. And so we do need to check that with washings and either cystoscopy for that. But the context of the disease can often predict the outcomes longer term. So if it's more superficial and distal, it's less likely to be more aggressive, more likely to present early, and often we're able to cure those. But if it's more proximal, deep, often presenting later at a more advanced stage, then they're more likely to have metastases at the time and a cure is less possible. Symptoms are similar, but more akin to urethral symptoms of, say, infection, inflammation, and discomfort. Same issues of some voiding symptoms, often with irritation or obstruction more so here. There's often a discharge, which can be bloody or it can be mucoid. And then patients can sometimes feel a sort of mass or bulkiness in the urethra. And if it has metastasized, then they may see lumps in the groin, because unlike bladder cancer, which spreads internally, urethral and penile cancer can spread to the groin lymph node, so it's slightly different. The assessment for that is, as we'd sort of say in our exams, which is sort of history examination investigations. And so examination, you may see some features at the meatus or see some bulkiness to the urethra. But thereafter, it's usually tests and investigations that we're going to need to use. So urine cytology or washings of the urethra can tell us if there are abnormal cells. The most useful scan, although we do use CT, is probably an MRI. It gives us better assessment of the penile, the urethral structures. And as you can see here, this is a female pelvis, and it almost looks like they've got a prostate here. And that's a diverticulum that's expanded with tumor. And so the MRI is much better modality for soft tissue lesions. So that's what we'd prefer. But then ultimately we need tissue diagnosis. So that's either with a needle biopsy or we're looking with a scope. And these are some irregularities in a urethra in that picture below. Generally, if we think it's curable, we try to resect these. If they're superficial, it might be possible with what we call sort of resections. So using a little hot wire or biopsying these, or we can even laser them away. If it's more aggressive or more advanced, then we're looking at more aggressive tumor. And this might be removing the urethra, removing the whole penis, up to major sort of resections. And so if you've got major cancer as a female, we're probably looking at cystourethrectomy because it's a bit difficult to reconstruct a urethra safely. And so we divert. Or we'd be talking about in men an exenteration, so cystoprostatectomy with urethrectomy if it hadn't happened already. There are other options in terms of conservative treatment, but the outcomes aren't compared head to head, and that might be radiotherapy such as brachytherapy. You might have heard of this in prostate cancer where they can insert little seeds, but then radiation can emit that and damage surrounding structures. You may have external beam radiation, but again, that can damage surrounding structures. Chemotherapy has been used, and so particularly in the HPV, we can use some chemotherapy agents such as gels akin to BCG or some of the chemotherapies, imiquimod or 5-FU. The outcomes aren't necessarily great. It's very hard to get dwell time, and so placing it and putting a penile clamp on is the only way possible in men. In women, it's almost impossible because you can't get a dwell time in a female urethra. And thereafter, some patients it's palliative and some patients it's surveillance for these diseases. Again, the survival with more advanced disease is quite poor. If it's caught early at a Ta/T1 stage, it's in the anterior or distal urethra, cure is possible, particularly when it's superficial, similar to sort of Ta/T1 disease in the bladder or the upper tract. But once we get beyond that, it's quite an aggressive disease. And similar to the ureter, there's not a great deal of surrounding buffer tissue. So as soon as it gets out, it gets into adjacent structures or it spreads to lymph nodes. And hence, unfortunately, we see quite poor outcomes for these patients. And so an index of suspicion, an early review, and particularly in patients who've had bladder cancer, if we're worried at all, it's regular urethroscopy, so passing a scope through there or getting washings to look for abnormal cells. Or removing it at the time. So that's a bit of a whirlwind trip through those two pretty large topics.